Further ado, I'm pleased to turn things over to Rachel to start off today's webinar.
Thank you, Tanya. And before I get started, I'd like to thank Scintica for the invitation to speak today, and thank you to everyone tuned in today. So just briefly looking at an outline of what I'll present today, I'll first look at a very brief intro of the current prevalence of COVID-19 and the pathophysiology as we currently understand it, really just to motivate the different imaging modalities and the different organs that I'll look at today. And then I'll finish off with a clinical outlook for patients who have survived COVID-19 and what their functional recovery looks like. So an important disclaimer before I get started is that the information that I'm going to present today is accurate to the best of my knowledge as of today or as of last night. As we all know, the current understanding of COVID-19 and its associated virus is rapidly changing, and there's new things available every day. And so as of last night, COVID-19 has, or the SARS-CoV-2 virus has infected over 23 million people and has caused over 810,000 deaths. Its primarily mode of entry into the human body is through the nasal and respiratory mucosa. And of course, the primary cause of morbidity and mortality is respiratory failure. But beyond that, it will typically progress into multi-organ failure from the lungs and can impact the brain, the heart, the liver, as well as the kidneys. And so, of course, because the primary cause of morbidity and mortality is respiratory failure, I'm going to begin with imaging of the lungs this morning. And so I'm starting with chest CT. But before I do, it's important to note that actually the most common modality used to assess the burden of lung disease in COVID-19 is regular planar X-ray. And this is in both the emergency departments as well as ICU. And this is because the radiation dose is extremely low, and importantly, the chest X-ray systems are portable. And so patients in the ICU, for example, typically undergo a chest X-ray every day. And so there's very large data sets available for COVID-19 chest X-rays out there. But I'm skipping over planar X-ray today in favor of chest CT because chest CT provides 3D high-resolution images of lungs and in most cases enables a deeper understanding of the pulmonary pathophysiology. So I'm first showing here a healthy image in the axial plane for reference for anyone who might not be familiar with looking at chest CTs. And then showing here some different example cases of COVID-19 to describe the most common radiological abnormalities we see on CT. Most commonly, there's peripheral ground glass opacities, which are highlighted by the red arrows here, and they're typically multifocal. And a ground glass opacity is essentially just described as a region of sort of foggy X-ray, a region of foggy X-ray on the chest CT. In more severe cases, the ground glass might progress into complete consolidation, where you start to see denser opacifications on the chest CT, and oftentimes in the posterior regions or in the lower lobes. And then another common finding is vessel thickening, as highlighted by these red arrows here. And of course, the primary findings are these ground glass opacities and consolidations, but while they're common, they're non-specific for COVID-19. And so these ground glass opacities are very commonly observed and typically indicative of pneumonia or infection in a more general sense, and can have a multitude of differential diagnoses. And I also want to make a point here that there's a lot of work going into automated detection and measurement of the extent of the burden of ground glass opacities in chest CT, and there's also been work going into regional spread of these CT changes, as well as sex differences between males and females. But I won't dive into those in the interest of time today. And beyond that, chest CT has been investigated as a way to predict outcomes in patients with COVID-19, and as well as an attempt to use chest CT in place of diagnosis, in place of the real-time PCR while results are pending. And so first looking at one study which compared chest CT findings in survivors and non-survivors of COVID-19, there indeed was a worse extent of CT changes in patients who did not survive COVID-19. But in an additional case report, it's also been shown that there are CT abnormalities, similar CT abnormality findings, while maybe not as extensive, but they're still present in patients who might not actually show any symptoms for COVID-19. So the diagnostic value for chest CT is slightly uncertain right now, but there have been guidelines established and published by the Fleischner Society here, which is an international group of chest radiology, and also by the World Health Organization. And switching now to look at the chest CT vasculature and perfusion, a possibly more unique finding in COVID-19 is what's called vascular tree in bud. And so I've outlined it with this circle here, but zooming in, vascular tree in bud describes when the vessels essentially become thickened and we're able to resolve them farther out on CT, and we're able to resolve the smaller vessels because either the vessels are becoming thicker or they're filling with blood clots. And so this arrow points to some smaller vessels that we would typically not be able to resolve on chest CT. There's been a few other investigations that have also used that have also measured perfusion defects and pretty consistently identify regions that are not well perfused in the lungs. And so this study in particular that I'm showing here has related the CT vascular findings to the formation of blood clots using actual blood samples from these patients. And so actually also showed that the CT vascular tree in bud pattern was predictive of patients who would experience longer days in hospital as well as longer days on mechanical ventilation. And so perhaps the vascular findings might be more specific for COVID-19 compared to the findings I showed on the previous two slides. And now again, I'm showing a couple axial CT slices from the same patient here. And this patient underwent a combined PET CT exam. And the PET images showed increased FDG uptake within these CT ground glass lesions. And the conclusion here was that this was likely related to inflammation inside those regions. But this was quite an interesting finding, I think, but it's important to note that this was an incidental finding on a patient who is asymptomatic for COVID-19, but undergoing a regular, or undergoing a PET CT as part of their regular workup for cancer. And so there's probably about 30 case reports like this one out there, but they're almost entirely findings on regular PET CT where these patients were completely asymptomatic, and COVID-19 was actually nearly diagnosed based on these findings. So there's limited prospective results of PET CT in COVID patients right now. And so here's where I'll switch over to the brain now and progress through some different organs beyond the lungs. CT has also been used to show a brain bleed, T2 weighted and diffusion weighted images here show these lesions in the brain that are indicative of artery occlusion, and this is all from the same study. To note, in another patient, susceptibility weighted imaging showed multiple susceptibility abnormalities, which were actually normal regions on a T2 weighted image. And so the important thing about these susceptibility weighted findings was that they were actually ovoid shape, which was a little unique to COVID-19. They're more generally round shaped, and so the ovoid shape was indicative of clots in the microvasculature within the brain. And switching quickly here into cardiac MRI, this was a study in 100 patients after they were recovering from COVID-19. And so these investigators performed T1 and T2 weighted imaging of the heart. And so I'm first showing, I'm showing the T2 weighted images here, where they measured T1 in the cardiac walls, and T1 was actually increased in those patients who were hospitalized and experienced worse outcomes of COVID-19. And they also showed late enhancement in the pericardial region pointed out by this arrow. And so both of these findings were essentially indicative of tissue damage inside the heart as well, and suggests that there might be persistent cardiac changes after acute COVID recovery. And there's been a lot of discussion about whether there might be a surge of heart disease after once we're through these possibly first 2 phases of COVID-19 illness. And so I'm going to switch into autopsy studies here, which I wanted to warn the audience that I am going to show some macro scale autopsy organ findings. So if anybody wants to sort of tune out for a moment here while I show these, if you don't want to see these, this is your warning now. And so I'll bring these images up here. So I'm showing some images from 2 different autopsy studies. The one on the left here investigated 7 patients with COVID-19 and compared to 7 patients with H1N1 infection. And the study on the right investigated 10 patients who had passed from COVID-19. And they both showed commonly pulmonary vascular clots, which are highlighted by the white arrows here. The study on this same study on the right also performed autopsy of the heart in these patients and demonstrated enlarged right ventricles. And bringing everything back for anyone, if there was anyone who did tune out, that was the last I will show of any autopsy findings. And so switching into histology results from these autopsy findings, first looking at the lung tissue to sort of confirm those CT findings, which I showed in my first few slides. Those ground glass opacities are essentially indicative of diffuse alveolar damage across the lungs. And they also, both studies also investigated the pulmonary vessels and showed clots within the microvasculature within the lungs, as one large clot shown here, and clots throughout the microvasculature in this slide. The study in the top row also performed, I believe it's CD61 staining to investigate the composition of these clots, and we're able to confirm that the clots were indeed composed of fibrin and platelets, and this hints towards the nature of the way that the clots are actually formed, and that these are clots that are forming because patients are now prone to more clotting. These are not clots that formed in the lower legs, for example, and then ended up inside the lungs. Again, the study in the top row also performed histopathology of the cardiac tissue, and these white arrows point to regions of damaged myocytes as well. Of course, it is important to note that these are very limited findings in a limited number of patients. And they're not, while what I'm showing here is consistent between the 2 studies, they weren't consistently even shown across these small samples of patients. So it's really difficult to make any certain points here. And the outlook of these patients and what happens to these patients after they do recover from COVID-19. And I think this is an important point to make, because there's been a lot of work and a lot of funding invested into more rapid detection and diagnosis of COVID-19 and for treatment of COVID-19. But now it's important to pivot to understand how these patients are recovering and whether they're going back to their pre-COVID-19 state. And so this first row is showing, this was a study out of China. This first row is showing a patient who had very mild chest CT abnormalities when they were first admitted to hospital, and by 2 and 4 weeks after discharge, their CT abnormalities had completely resolved. But in contrast, on the bottom row here was a patient who had more extensive CT abnormalities that some of them tended to persist up to 4 weeks after hospital discharge. And so at the 2-week time point, about 26% of these patients had completely recovered on CT, whereas at 4 weeks, approximately 65% of patients showed a normal CT. And beyond this, there's also been some reports showing persistent symptoms up to 2 months after COVID-19 illness. And just a summary here before we switch over and before we turn it over back to Tanya and over to Patrick. The important thing to note is that what I've shown here does help us to understand the in vivo and post-mortem pathophysiology of COVID-19. And of course, I've primarily focused on chest CT in active infection as well as in follow-up. The autopsy suggests a microvascular thrombosis, but it's hard to make any conclusions. And the clinical outlook for recovery for survivors is really uncertain right now. And the limitations, of course, of everything I've shown is that studies are entirely retrospective and in very selected patients, and in most cases, they're very small sample sizes. And the common underlying message here you might notice is a lot of uncertainty. And so my presentation today might leave you feeling a little bit uncomfortable. There's still a lot of uncertainty and there's still a lot of uncertainty in the current understanding of COVID-19, and this is really inherent to the nature of the pandemic and its rapid worldwide onset and highly infectious nature of the virus. Prospective studies have been nearly impossible, and so that possibly uncomfortable feeling of uncertainty motivates a new question and motivates seemingly backwards from typical translational research from patient bedside to research bench. And so how can clinical results inform mechanistic and prospective preclinical studies? And here's where I will turn it over to Tanya. Thank you.
Excellent. Thanks, Rachel, so much for the fascinating discussion thus far. We do want to take a really quick break here and ask the audience to tell us a little bit more about the research that they're doing. So the first question that should come up is, are you using imaging in your research? So yes, and you're happy with your imaging capabilities. Yes, you see a need for expansion or addition to your imaging capabilities. No, but you'd like to start adding imaging to your research. And no, you're just here to learn more about what others are doing in their research. Secondly, which imaging modalities are you using in your research, if you are using any at all? MRI, ultrasound, PET, CT, optical, others, and if you choose others, if you can specify in the chat dialog box, that would be delightful, or none at all. I'll give everyone a couple more seconds just to log in their responses. Excellent. Thanks for taking the time. It does look like a number of you are using imaging in your research, and it's kind of spread along all the different modalities that we discussed there. So at this point, I'd like to thank you all for answering those questions and turn things over to Patrick for the next part of his discussion.
All right, thank you very much, Tanya, and thank you, Rachel, for taking the chance to walk us through the clinical effects and clinical imaging of COVID-19. So what we're going to talk about today is a little bit different than what we traditionally present. And right now, what's taking place with COVID, as you saw, is the immense amount of uncertainty in clinical imaging. And because of that, it makes some preclinical imaging very useful, but also very difficult. So we're going to sort of go through a roadmap of how we might integrate imaging into this preclinical study of COVID-19, and also how we as from Scintica Instrumentation might be able to support that. So as preclinical researchers right now, I know for myself, many of us have felt like we're sort of stuck on the sidelines. A lot of labs and institutions are closing entirely for this time, and several of us are starting to get back into the lab. But it's been a long road as we sort of wait, and everything, rightfully so, focuses on clinical treatment and imaging. But as preclinical researchers, our aim is still the same as clinical research. We want to increase that knowledge and hopefully down the road translate that to novel treatment possibilities and improve patient outcomes. And further, on a practical note, currently, research funds are inevitably going to follow clinical trends in a pandemic such as this. So there's a large-scale push right now to integrate aspects of COVID research into either an existing research program or develop new ones. So this presentation is really going to focus on how can we as preclinical researchers start to take part in that fight against COVID-19 as our labs are starting to open back up. And specifically, how can we integrate various preclinical imaging techniques to help us in that fight? Now, before we get into specific imaging techniques, I think it's really important for us to just give a brief discussion of various preclinical models of COVID-19. Now, there's a natural divide when we're talking about studying this disease, this virus in the preclinical setting, and that comes with the fact of what biosafety level you're working at. So if you want to work with the COVID-19 virus, you need to be, if you're working with it directly, you need to be in a BSL3 or a BSL4 lab. So these labs require comprehensive PPE, safety protocols, security. Many of you I saw that are attending this work within these labs. If you have access to these, you can work directly with COVID-19. And we've actually been hearing that a lot of different institutions across the world are rapidly developing different lab space into a BSL3 or higher laboratory so they can join in this fight against COVID. So there are more and more researchers gaining access to these different labs. Now, if you don't have these, you have to approach this research in a different way. So we're going to sort of split this into what models you can use in BSL3 and what you might have to use for surrogate models. So if you're looking for animal models in BSL3 and you're lucky enough to have access to those laboratories, you can use this COVID-19 virus directly in your work. But what they have found so far, which is unfortunate, is that this virus shows limited effect in traditional rodent models such as mice and rats. So there's been a lot of rapid development going on into alternate animal models. One of those models that's specifically been used quite a bit is the golden Syrian hamster. And the reason for that is because this animal model has shown high susceptibility to this infection. Now, also ferrets, cats, and non-human primates have been shown to be susceptible to this virus, but as many researchers know, as soon as you start to get into those larger animal models, the ethics guidelines take quite a bit more to get those through. So a lot of work has been focused on these golden Syrian hamsters. Now, there are quite a few different mouse models being developed, mouse and rat models. So there's various transgenic mouse lines that are expressing the human ACE2 receptor. And we're going to talk a lot about that ACE2 receptor as we move on. But for now, this just shows it's one model of this COVID-19 virus in rodents. There's also ways to infect rodents using an AAV9 viral vector and cause them to express human ACE2 receptors, and then you may expose them to that SARS-CoV-2 virus. And then, of course, you can also modify the virus to increase affinity for rodent ACE receptors. But of course, you want to limit this. Most labs are sort of shying away from too much modification of the virus itself. So there's lots of different ways to incorporate this into your work if you have access to a BSL3 or BSL4 lab. Now, where it gets a little bit more tricky is if you don't have access to those labs, right? So now you're looking for ways to integrate this work into your research, but you can't actually use the virus itself. But there are still many opportunities to study COVID indirectly, and to do that through various surrogate models. So these surrogate models will mimic specific aspects of the disease. Some aspects you might want to mimic would be, say, the lung injury seen in COVID, the immune response, both systemic and localized, various cardiovascular abnormalities, and the neurological damage we're seeing. By mimicking these specific aspects, researchers can then test these specific hypotheses with regard to, say, disease progression or potentially intervention. So the most obvious area of study currently, and one that's rapidly growing in response to COVID, is these preclinical models of lung injury. So as Rachel alluded to, a huge amount of deaths are attributed to respiratory failure within COVID patients. And so similarly, it's a good area of study for preclinical models, perhaps to test disease progression again or efficacy of a particular treatment. So the most common model of lung injury being used currently is the lipopolysaccharide model, or LPS model. This has been used extensively well before COVID. And this one is really effective because it actually mimics a lot of the inflammatory response that we see in COVID patients. So this one is very, very well documented and well controlled within the laboratory environment. There's also the oleic acid model of lung injury, which is less used, but this can mimic some aspects, and it's directly toxic to endothelial cells, which again makes it a little bit, or makes it very relevant to COVID research. Also, there are different influenza infection models that you can use outside of those specific biosafety laboratories. And while they are very, very different than COVID, they can elicit a pronounced immune response. And what that can do is lead to acute respiratory distress syndrome. And this is one of the hallmarks seen in COVID patients. So there's many different ways to study aspects of that lung injury model without having access to the virus itself. But of course, as I alluded to previously, COVID is much more than just a respiratory disease. It was, very much focused on the respiratory distress that patients were feeling at first, and now we're seeing widespread systematic damage to the body. And it's thought that this is due to the fact that COVID enters the body through the ACE2 receptor. So the ACE2 receptor is a protein, and what it does is it helps to modulate the many activities of angiotensin II. And you've probably heard of angiotensin II and various other research applications. Angiotensin II works to increase blood pressure, various inflammatory processes, things like that. So it's heavily involved in the immune system. So ACE2 is also present in many cell types. You have it present in the lungs, of course, the heart, blood vessels, kidneys, liver, gastrointestinal tract, so it is all over the body. Because of this, we start to see why we're getting this systemic response to COVID in these patients. It is affecting the whole body through this ACE2 receptor. And basically what COVID does is those little red spikes that we see in all the images, these spike proteins actually attach directly to that receptor. Now, the one good side to this is the ACE2 receptor has been heavily studied before for various diseases, especially in response to blood pressure and hypertension. So many preclinical models have been developed previously to look at rats or mice expressing this human ACE2 receptor. I've listed a couple here. These are just example models, but what is nice for COVID researchers outside of those BSL2 and 3 laboratories that want to take part in this research is there are quite a few models already available and well documented and controlled of this ACE2 receptor. So it gives you an avenue to start a research program or adjust slightly to your existing research program without waiting for subsequent models or without building an entire BSL2 or BSL3 laboratory. So as again, those are just a few examples of models. There's extensive work going on to develop different ones, and I'm sure some of you out there are actually already using some. And if you are, we'd love to hear about it. So feel free to let us know what different models and work you're doing in yours. But as we think about some of those models, and we want to think about how we can integrate preclinical imaging into COVID, we do have to rely on various other diseases and pathologies, right? There's so little preclinical information published so far that we really have to look back to what's already been done and see how we could integrate that into our current workflows. So of course, we're going to go through a few of these different modalities, and we'll start with CT as Rachel discussed here. It's heavily used, CT and X-ray, in these various clinical applications. So with CT, you use that combination of multiple X-ray measurements. You take them from different angles to produce cross-sectional images. This is very, very effective in lung imaging, angiography, and cardiac function. Various other applications, but if we're tuning this specifically to COVID imaging, these are the most effective ones. Here's an example, and this is not in COVID, right? But this is an image of a pulmonary fibrosis model. So pulmonary fibrosis is seen now in COVID, and we can see how these CT images can really light up some of the tissue densities. So you see here the hyper intensities, so the lighter parts, which you see extensively in this image here. These are indicative of higher tissue density in this image, and those higher tissue density is downstream indicative of different fibrosis and pathological processes taking place. So in this example, they were testing the efficacies of 4 different treatments. And you can see a very, very stark difference between each of these images representative of that. So this might be an opportunity to integrate CT into your work if you want to do some in vivo monitoring and tracking of different drug treatments in a lung model. Again, there's many other ways to integrate this, but this is one example that we wanted to draw on here. Now, what's really interesting is starting to integrate multiple different modalities into your work. So this is an example of integrating positron emission tomography, or PET imaging, with CT. So PET imaging is a nuclear imaging technique where we follow different radio tracers throughout the body. Now, by integrating this with something like CT, we can get both functional imaging capabilities by following the distribution of that radio tracer, and we can also get some of that structural information gained from the CT. So this is actually an example of imaging that LPS, that lipopolysaccharide-induced inflammation model. So if you wanted to use something like this, and we can see here distribution of that a radio tracer that is going to localize to the inflammatory process. So this is highlighting where that LPS-induced inflammation would be taking place before and after treatment. Then by combining it with that CT image, we get a really nice, we get a great ability to localize that image. So you can map out, say, the temporal response of the inflammatory response with something like that. You could, again, look at the efficacy of treatment. Lots of different ways to integrate this into your research. Now, MRI is my background, so I'm definitely a little bit partial to this, but there's various ways you can introduce MRI into your COVID research. Now, the most obvious and one we commonly go to is neuroimaging. You can see here, this is an excellent example of this. And it's just going to slowly traverse through the brain of a rat here. You can see really, really nice contrast here. You see the corpus callosum, hippocampus of this image. And this is one of MRI's incredible strengths, the soft tissue imaging and particularly neuroimaging. So if you wanted to potentially study some of the neurological correlates of COVID, perhaps some of those microbleeds in the brain, something like that, MRI would be well situated to look at that depending on the model you're using. But MRI is not specific just to the brain. There's plenty of opportunities to use it for lung imaging as well. Here we see an example of an infected lung. So this is actually infected with a fungi, but you can see the control here, very, very clear all the way through. You see after 4 days of infection, in this case, the different pathologies appearing on the MRI. So there's another opportunity to image different lung pathologies, and this time using MRI. Now with MRI, of course, you can also combine it with that PET imaging, similar to what we discussed with the PET CT. Here's a couple really interesting examples of how you might do that to visualize both structure and function. So on the right here, we have, again, that LPS-induced inflammation model, but now we're looking at neuroinflammation. Now, neuroinflammation is starting to be shown as we see more and more COVID patients. So if you wanted to mimic some of that and then track it in vivo, using simultaneous PET MRI is a fantastic option here as we see the biodistribution of that PET radio tracer. On the left, we have another example of lung imaging here. And this is again with a fungal infection, but it's using MRI to look at different treatment options for a fungal infection in the lungs here. So we get really, really nice anatomical information, and then we can see the biodistribution, the control. Well, there's not much here. And then we see with the fungal infection here, we see a large accumulation of that radio tracer in the lungs. So again, another way to look at, different inflammatory processes and different infection processes in the lungs. Now, ultrasound isn't traditionally discussed right now using COVID, but it definitely has its place within the preclinical research community. So ultrasound, you're using high frequency sound waves to view inside the body, and you can get some fantastic in vivo images in real time. So this is an example of cardiac imaging in real time here of a mouse heart. But one really interesting application that ultrasound could be used for, and we show an example here, is tracking of abnormalities in the vasculature. So this is an example of using ultrasound to track the formation of an angiotensin II induced abdominal aortic aneurysm. So this is a genetic defect where people are susceptible to these abdominal aortic aneurysms. And this is actually a group that is at particularly high risk with COVID due to the increased cardiovascular abnormalities. So this is an interesting example of tracking the size and shape of that in vivo using ultrasound. It's easy and quick to use. And if you want to, say, mimic some of those aspects of clotting or thrombosis in a model, ultrasound might be a fantastic option to monitor those and track those in vivo here. And the last technique we're going to quickly talk about here, and something you might be able to integrate into your work, is optical imaging. So we're looking at bioluminescence and fluorescence imaging. This is a really, really nice opportunity to track biodistribution and processes in vivo here. So in optical imaging, you have some cell or some tagged particle, and you allow it to distribute and move throughout the body through various processes. And then basically you are able to track where it goes based on the amount of photons it gives off, and you're able to count those. So, So here we see, this is another image of a viral infection through the lungs, and you can see the biodistribution over time of these various particles moving towards the site of the viral infection. And then here we see before and after antiviral therapy. So this is a great, again, way to look at the efficacies of different therapies along the way. Again, this is also one that can be integrated in with different imaging modalities. So you see here the BLI, or that bioluminescence imaging, and then you see that same animal that has had a PET CT taking place. So you see this distribution here, and then you can localize it a little bit more using something like PET CT and gain more anatomical information. So it's a really interesting way to track things and track a functional process taking place within the body in vivo. So we're just going to turn this over to Tanya real quick here for another audience poll, and then we'll briefly discuss some of the things that Scintica may have to offer your research program.
Excellent. Thanks, Patrick. And like he mentioned, we would just like to stop here quickly and take a brief poll. So the questions here are, do you currently have access to a BSL3 or other containment facility to work with the live SARS-CoV-2 virus with your research? Answers are yes, we are currently working within the containment facility, or yes, we are not currently completing our studies with the live virus, but you do have access to a BSL3. No, but we hope to or have already secured funding to build a new containment facility. No, we will be looking to find other ways to adapt our current environment to study various aspects of COVID-19 disease process. No, I attended simply to learn more about what others are doing in their research. And the final question that we have today is, which of the following would you like to learn more about from Scintica Instrumentation's product portfolio? And so Patrick will cover these in the next slides, but as an example, we have PET CT system, MRI, high frequency ultrasound, as well as an optical imaging system that we'd be happy to chat further with you about. I'll give everyone just a couple more seconds to respond to those questions. Perfect, excellent. So it doesn't look like there's too many people that are currently using the virus in a BSL3, and that's not surprising as the models are just still being developed. But there's several of you who hope to in the future as we go forward. And there's lots of interest in different imaging modalities. So at this point, I'd like to turn things back over to Patrick for the final section of his talk.
Excellent, thanks again, Tanya. All right, so I'm just going to briefly go through some of the things, some of the products we have at Scintica with the idea we want you to know we are here to support your preclinical research. And I'll quickly go over these, but we'd love to hear from you what you need to really boost your research program and get these things moving for you, as there is sort of a rapid shift in research right now and a lot of people returning to labs. So we've talked a lot about CT and PET CT. So one of the products we offer is the Sedecal SuperArgus PET CT. So these are state-of-the-art systems, and they vary in size. So you can do molecular imaging as small as mice all the way up to marmosets, rabbits, non-human primates. And these are really interesting due to their unique phosphate detectors that Sedecal has produced. So these detectors provide true depth of interaction information and a sub-millimeter resolution uniformity across that entire field of view. And they have excellent parallax error correction. So these offer really, really high performance detectors within this PET CT system. So you can use this as a standalone PET system or a standalone CT system, or you can combine them and it's all integrated together. So it's really nice to have this system fully integrated. It allows for easier comparison between the two modalities. Now, we did discuss MRI, and one of the products, again, that we offer is the Aspect Compact Preclinical MRI. So this M-Series Compact MRI is really, really easy to use. And as you can see right there, anyone who's familiar with MRI is probably going to blink and look at this twice. That is the real size of that system. And that is a normal size chair sitting right beside it. So this is an incredibly compact and low footprint system. It's cryogen free, which is really excellent. It requires no liquid cooling. You can literally wheel this in and with small modifications, plug this into the wall and it's ready to go. It's very easy to use and it's designed for both MR physicists and those who have not used MRI before to be able to use. So it's a very, very excellent and easy to use system. We've talked a lot about PET imaging and integrating that. And one way to integrate PET imaging in with MRI is a product we offer from Brightonics called the SimPET. So this is an advanced silicon photomultiplier based PET insert. So it can be used on its own as just a PET imager, but this is designed to integrate with various MRI scanners. And specifically, it's designed to integrate with the Aspect M7 scanners. So together they represent the first complete and most cost-effective permanent magnet PET MRI solution. So again, a very, very low footprint for both of these things. You can actually have both of these within a 10 by 10 laboratory, including all workstations, electronics, limited shielding requirements, and power consumption. So this is a really nice option for those that had thought MRI and PET was traditionally unavailable due to siting requirements. This really opens the doors for those researchers. And I know many in the BSL3 and BSL4 laboratories would be very interested in these systems for that reason. Now going on to the ultrasound system, we offer the S-Sharp Prospect T1 ultrasound. So this system is a very cost-effective, high-frequency preclinical ultrasound system. So it's designed for use with mice, rats, other small animals like that. But it can be modified ever so slightly. And it's been optimized mostly to study hemodynamics and vascular function. So it has excellent ability to do that sort of stuff, which is particularly relevant in this COVID research. And then lastly, we want to talk about our optical systems. So this is the bioluminescence and fluorescence system. So the Newton 7.0 provided by Wilbur here. This system offers, like I said, bioluminescence, fluorescence, and 3D tomographic imaging. It's quite easy to use, very user-friendly, and it can be used for in vivo, ex vivo, and in vitro imaging applications. What's really neat about this as well for researchers is it allows for multiple animals or samples to be imaged at the same time. So you can have several, anywhere from 3 to 5 animals in this system at a single time. So it's very, very user-friendly and offers quite a bit of utility at a small footprint and low cost for this system. So again, these are just a few of the things we offer here at Scintica Instrumentation. And one of the reasons we really wanted to do this webinar was to indicate to you that we are available to support the preclinical research community as they join this fight against COVID. And some are already part of it, but we know there's a rapid change in research, and a lot of researchers are trying to adjust to this new landscape, especially in the preclinical realm. If at any point there's something we may be able to do for you, whether it be product information, help with study design, grant applications, we are always ready and willing to help the research community with that. So don't hesitate to reach out to us either now through the Q&A or at any point in the future. We'd love to discuss some options for you and help you in your research as we move forward. So with that, I'm going to turn this back over to Tanya, and she'll take the lead on the Q&A session. I just want to thank you for taking the time to join us so far today. I'd love to hear what you have to say in this Q&A session.
Excellent. Thanks, Patrick. And again, thank you, Rachel, for taking the time to join us. We'll now take some time to address some of the questions that came in throughout the webinar. And I do encourage anyone who has additional questions to put them in the Q&A dialog box available to you at the bottom of the screen. And I'll go through those with Rachel and Patrick as appropriate. So the first one looks like it's more centered towards the start of the presentation with Rachel. And you focused a lot on CT, but has other imaging been completed clinically, for example, PET and ultrasound?
Yeah, that's a great point. I'll start with PET because it's easier to sort of knock off the top. There's probably about 30, I would say, PET CT case reports in the literature, which are entirely incidental findings. There was one case report out of China that did a full workup on a single patient of cardiac, brain, lung PET MRI, which I actually learned about at the virtual ISMRM conference this year. But otherwise, the nuclear medicine studies are a little bit more limited to the incidental findings. As far as ultrasound, the most common application I've seen of ultrasound in the clinical literature is to investigate deep vein thrombosis. So pulmonary blood clots are very common, and ultrasound's been used to investigate whether those clots are forming and sticking in the lungs or whether they're coming from a deep vein thrombosis. and they are indeed not coming from deep vein thrombosis and are forming in the lungs. As a side note, ultrasound is a bit of a debated topic in the pulmonary medicine field in general. It's a bit limited for the lungs to detecting perhaps a pleural effusion, to detect any water around the lung cavity. And then in terms of COVID, for active COVID infection, it's also a bit limited, and there's some debate about being able to disinfect the ultrasound probe properly and being in too close physical contact with the patient. So it's a little bit of a debated topic right now.
Fair enough. Excellent. Thanks for the insights. This one focused more towards Patrick and perhaps myself as well. Can the imaging systems that you talked about, Patrick, from Scintica be positioned within a BSL3 lab, and maybe talk about some of the specific examples as it relates to the containment facility and the issues with getting materials in or therefore out of the facility once you're finished?
Yeah, that's a great question, and obviously one of the biggest limitations to integrating imaging behind those barriers. So the answer is yes. These can all be brought behind the containment facility and integrated into those workflows. Like I briefly touched on, the most surprising one would be having that MRI capability within a BSL3 and 4 containment laboratory. If you're familiar with MRI, traditionally you need cryogen cooling or even possibly liquid cooling for some systems. And that's not necessary for the Aspect system. So that really opens the doors to integrating that within that barrier, which is quite different. But all the systems certainly can be brought behind the barrier. Some of them, we've been speaking to various customers and researchers about integrating some specific safety protocols for animal handling and things like that. And we're more than happy to work with people as, we understand behind these containment facilities, and even just within BSL2 sometimes there are some specific applications that require minor adjustments, and we're more than happy to work with people and discuss some of the possibilities when it comes to that.
Yes, agreed. So part of that is the development of basically an imaging cassette, which would be isolated from the surrounding environment, such that you could still use isoflurane and exhaust the gas out, but put a HEPA filter in between to allow the virus to be contained. So that's something that we're actively working on. I guess to add to that, so the MR system Patrick alluded to, basically there's no cryogens or liquids needed to cool them, so you don't have to deal with those fluids. The PET-CT system is also self-contained, so it is shielded on the CT component, so there would be no additional infrastructure needed for that installation. So all of the systems work quite well within a BSL3 environment where space is tight and you don't really want to have to build extra infrastructure to facilitate adding one of those systems to the environment. A few other questions that came through. One of them was perhaps a little more technical, and Patrick, perhaps you can help answer it, is how to handle motion artifacts with respect to both MR and CT when doing it combined with PET.
Yeah, well, that is a whole other area, I guess. I'm more familiar with MR motion artifacts than if you're thinking of, say, lung imaging or something. There's various gating possibilities. A lot of motion artifacts in neuroimaging are commonly post-processed. And then when you're talking about integrating them with PET, the good thing about the systems we've discussed here, say something like the Aspect and the SimPET, it is designed with that end user in mind, where the software has possibilities. So you're looking at registration between images, which is really important. Attenuation correction. Both of these systems have their own attenuation correction built in. So obviously MR is MR-based attenuation correction, and CT is CT-based. So they do have those quality controls built in. If you're thinking of, say, integrating something like the SimPET with an already existing system, it begins to get a little more challenging, but certainly doable. There's various, again, software options, and there's also a lot of third-party software options to do quality control on these images, depending exactly what you're looking for. If you're looking at MR time course images, there's a lot of registration possibilities when it comes to correcting for those sorts of motion artifacts and things like that.
Perfect, excellent. And then one final question that we'll address just as we reach the top of the hour is what sequences are available on the M7? And I pulled up the document to help Patrick out on this one, so I'll read off the sequences that are available for the audience. And then there are a few other questions that we haven't had a chance to answer, but we will address those in a Q&A transcript that we have after. So in terms of the sequences that are available, on the M series system, there's a spin echo, fast spin echo, gradient echo, inversion recovery, fat water separation, kind of the whole list. And again, in the transcript, I'll include the entire list of both sequences as well as procedures and protocols that are available for that system.
Yeah, if I might add to that,
yeah,
Tanya,
sure.
within the user face of our user interface of the aspect, you know, we have those standard protocols in there. But even as a novice user, there's some options. You know, you want to be able to adjust your echo times and your repetition times and things like that to adjust your contrast slightly. And those are definitely available even to someone without you know, you don't need to do the pulse programming or anything like that. The user interface allows those sorts of things. So you can adjust a lot of these to suit your needs when it comes to these pulse sequences.
Yes, exactly. And then also typically part of a system installation includes on-site training or remote virtual training in these days of the COVID pandemic to help you optimize your sequences. So all of those things are available.
Yes.
But at this point, we have reached the 60-minute mark of today's section, and I do want to be respectful of everyone's time. So I'd like to thank Rachel and Patrick for their time today, and I trust that we've been able to provide you with a bit more information that is relevant to the work that you're doing, or give you some ideas of how to adapt to the current funding situation. However, if in the days to come you have further questions and you want to reach out, as Patrick mentioned, we're more than happy to talk about the systems that we have, the research that you're doing, and perhaps how they complement one another. So again, I'd like to thank everyone for taking their time to join us today and hope that we see you all at a future Scintica event. Thanks again, everyone.